Hello everybody and welcome to today's webinar, ICG in Gynecology and Gynecological Oncology. Before we get started, I would like to go over a few items so you know how to participate in today's event. You may have joined the presentation listening using your computer's speaker system by default. If you would prefer to join over the telephone, just select phone call in the audio pane and the dial-in information will be displayed. We welcome your questions and you will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of your attendee control panel. You can send your questions in at any time during the presentation. It's my pleasure to introduce our presenter today, Professor Michael Mueller. He's head of the Division of Gynecology and Gynecological Oncology at the University Women's Hospital in Bern, Switzerland. He has had more than 250 publications in peer-reviewed journals and more than 20 book chapters. In 2000, he won first prize for the best scientific work in gynecology and has won 40 first prizes for scientific posters, 30 prizes for best videos and other scientific awards. As a special guest for today's Q&A, we have Dr. Jordi Ponce joining us. Dr. Ponce is head of the Gynecology Service at Belvita University Hospital in Barcelona, Spain. After Professor Mueller concludes his presentation today, Dr. Ponce will be moderating our question and answer session with you, our audience. We look forward to an interesting session. Professor Mueller, over to you.
Thank you very much. Thank you very much for the kind introduction and for giving me the opportunity to speak about the topic that I especially like and I'm interested in, the application of ICG in gynecological procedures. I will speak about the ICG in the detection of sentinel lymph node, ICG in endometriosis, how we can use it, also to label the ureter, ICG in laparoscopic myomectomy. That's one of the last things we started to do. So first, speaking about the sentinel lymph node, I think it's very important to realize that when we speak about the sentinel lymph node, we speak about the first lymph node to which cancer cells are most likely to spread from a primary tumor. A sentinel lymph node helps to determine the extent or stage of cancer in the body, but it's very important to realize that we speak about the first lymph node at all. One of the big questions was for a long time, which tracer to use. I think that this question is now resolved because ICG has less side effects than the classical technetium and blue dye. This is a review we did already a couple of years ago, but you see when we use blue dye, we have about 2% of severe allergic reactions, and I think that's really bad. Furthermore, we have other toxicities like discoloration of the skin, discoloration of urine, skin necrosis. That's why I think it's more important and better to use ICG. Especially that when we look at gynecology, we have some randomized studies, meaning we have evidence that ICG is better than other tracers. This was the film trial performed 3 years ago, where actually they randomized 180 patients. 90 patients had first isosulfan blue dye injection followed by ICG injection, randomized to 90 patients who first had ICG injection followed by isosulfan blue dye. And you see that actually the sentinel lymph node detection was significantly higher in the patients who first got the ICG. And I think even more important, the bilateral detection rate was statistically significantly higher when using ICG than when using the blue dye. So the conclusion of that paper was that ICG with near infrared fluorescence imaging identifies more sentinel nodes than isosulfan blue dye in women with cervical and uterine cancers. So there are other retrospective studies about that, and another prospective study randomized that showed exactly the same. So I think that when we speak about the detection of sentinel lymph node in gynecological oncology, nowadays, I think it's used and it's normal to use ICG. I will speak about ICG detection in cervical cancer, endometrial cancer, which are standard procedures, in ovarian cancer, where it seems that it works also, and just say a few words about vulvar cancer, which is a special and very important disease when we speak about sentinel lymph node. So we started a couple of years ago using ICG in the detection of sentinel lymph nodes in cervical cancer. At that time, in our first study, we compared actually ICG to a retrospective group where we used the classical ICG, sentinel technetium and blue dye. And you see that actually the ICG detection was higher than technetium and blue dye, but I think, and that's very important, the bilateral detection rate was already higher in that time than when we compared it to the technetium and blue dye. The location of the sentinel lymph nodes we detected at that time was actually the classical one, also shown in the Sentinel study. We then pooled our data together with 5 other European centers looking at the same questions, meaning detection of sentinel lymph node in cervical cancer stage 1A2 to 1B1, 144 patients, and we compared the detection rate using ICG compared to standard technetium and blue dye, and had actually exactly the same results that we had initially, meaning that ICG had a much higher bilateral detection rate, which is the really important one, than the classical technetium and blue dye. At that time, we concluded that laparoscopic sentinel lymph node mapping with ICG appears to be safe, easy, and reproducible. So I was very happy when then I saw the first meta-analysis done by Ulain a couple of years then, and that meta-analysis, which actually compared and looked at the detection of sentinel lymph node in cervical cancer, and the conclusion of that meta-analysis was that actually ICG versus a combination of 3 other traces showed significantly higher bilateral and unilateral detection rates, that ICG had a higher bilateral detection rate than blue dye and technetium, and the definitive conclusion was that ICG is superior and better than other traces in patients with cervical cancer. So nowadays, in patients with cervical cancer, we use only ICG. And even there is a LAC study that showed that we shouldn't do minimal invasive surgery in those patients. We first look at the sentinel lymph node by ICG, then proceed to the open surgery if needed. Very importantly also is to realize that one of the advantages of ICG is that you might use it in pregnant patients. So here it's important to mention that this is off-label use. However, we know, because ICG is known since a long time ago from the ophthalmologists, that if patients are pregnant, that is not a problem for the patient or the baby. Cervical cancer might be diagnosed in pregnant patients. And I think there it's very important to know how the lymph nodes are. The only way to know that is to do a sentinel lymph nodectomy, and here, as mentioned, off-label use, but you might use ICG. Where ICG, sentinel lymph node, made the big changes or more changes in looking at the gynecological question is in patients with endometrial cancer, because those patients are often patients having a lot of other comorbidities, are older patients, obese patients, where actually we really want to minimize the surgery as much as needed. We started just after looking first at cervical cancer, also with endometrial cancer. And there actually we did the same study in endometrial cancer, so looking at endometrial cancer only. Most of the studies before that were kind of a mixed group between cervical and endometrial cancer. So this one was one of the larger studies looking at endometrial cancer stage 1. 342 women could be included in 5 different European centers. 195 had ICG alone, and 147 had technetium and blue dye. And you see that the overall detection rate was about similar in both groups, but again, there was a huge statistical difference when we look at the bilateral detection rate. ICG had a much higher bilateral detection rate, a statistically significant higher detection rate when looking at the bilaterality. And I think this is the very important part. So nowadays, it's also standard to use ICG when we look at the sentinel lymph nodes in patients with endometrial cancer. But here I think there are a couple of few important technical points to mention. And there was a very interesting Italian study that just came out 2 years ago, where they looked actually at what might be the reason for unsuccessful sentinel lymph nodes. So one of the important things is the expertise of the surgeon. So in our experience too, it needs about 15 cases to have a good expertise to really see and find out the real sentinel lymph nodes. But to me, more important is really that we always start with the laparoscopy. And it has been shown in that Italian study that the lysis of adhesions is an independent factor associated with unsuccessful procedure. And that's the reason why we always start with the laparoscopy. If we have adhesions like here, we first dissect the adhesions, just take everything so that we can then go and inject the ICG. Usually it takes 6 to 10 minutes after injection to see the ICG coming. One of the important things we realized in the last couple of years is that in all the patients, it takes often a longer time until you see the lymph vessels coming. But the big advantage of ICG is that it allows a dynamic localization of the sentinel lymph node, so you really see the true sentinel lymph node. Later, I'm going to speak about the problem of the enlarged lymph nodes because that's a problem in sentinel lymph node in general. So the question is where to inject the ICG. There was a nice study published already a couple of years ago by a Swedish group where they injected the ICG either in the fundus of the uterus or in the cervix. And they could demonstrate that actually the pelvic pathways and positions of the sentinel lymph nodes are independent of the tracer injection site. But again, the important part are the bilateral detection rate, and they could demonstrate that you have a higher detection rate when you inject the ICG in the cervix. So the cervical injection is preferable due to a higher technical success rate in patients with endometrial cancer when you compare it to the fundus. Importantly, in that paper, they could demonstrate 3 different pathways, one upper paracervical pathway, a lower paracervical pathway, and the infundibular pelvic pathway. However, if you inject it in the cervix, then the detection is more importantly bilateral. The other very interesting study has been published last year by an Italian group. They randomized patients with endometrial cancer either in a group where they injected the ICG in the cervix or peritumorally by hysteroscopy. What they could demonstrate is actually that they had a little bit more sentinel lymph nodes parotic in the hysteroscopic arm. However, the bilaterality was much higher when they injected the ICG in the cervix. And that's why the conclusion of that paper was also that the cervical injection has to be adopted instead of the hysteroscopic injection because it allows a better identification of the sentinel lymph nodes in the pelvic area and even you have a higher parotic lymph node, the difference with the cervical injection route is not statistically significant. So I think that's the other point where everybody agrees. It's sufficient if you inject the ICG in the cervix. So the question is how to inject that in the cervix. And here there are also a lot of different techniques. We use actually the one you see here. So we inject actually at 4 different cardinal points, 1 centimeter deep in the stroma and 0.5 just submucosal, but other groups in less and at different points. I think this is one of the topics that has to be discussed in the future, where we need more clinical data to be exact, that everybody has the same instructions. We know that there are 2 different pathways, common drainage routes of the ICG. One is the common drainage route, where actually the lymphatic trunk crosses over the obliterated umbilical artery, and the most common locations of the sentinel lymph nodes is actually medial to the external iliac, often in the obturator fossa. Then there is the atypical way, where the lymphatic trunk follows the mesoureter cephala to the common iliac and presacral sentinel lymph nodes. So that's why it's always important to look at those sentinel lymph nodes. And I mentioned that ICG is a dynamic way to set it. And I think that's what we also see when we perform the laparoscopy, that we really see those different pathways. Another very important technical point is that all that glitters is not gold. So even if you see a green lymph node like here, that isn't the sentinel lymph node. You remember the definition, it's always the first lymph node. And that's why you have to follow the different lymph vessels to really find then the sentinel lymph node that we have here. So that's very important. That's why I showed you the difference, the definition, because when you look or do ICG at the beginning, you're just happy because everything looks green, but you have to follow the lymph vessels and find the real sentinel lymph node, which is here in this patient. Then the other point I mentioned is the enlarged lymph nodes. Are the enlarged lymph nodes? I think that it's important that if you have enlarged metastatic nodes, they might be without any coloration. You have always to take enlarged lymph nodes because the lymphatic channel might be blocked by tumor cells. So you might have a green colored lymph node, but that's not the sentinel actually, because the enlarged lymph node might be the metastatic one or having the metastatic disease. So I think it's important always to look for those enlarged lymph nodes. The study that you probably all know, but I think that's very important to realize, that even in a multi-center prospective study, you have a high sensitivity to detect node-positive disease. And that was done in the FIRES trial, where actually 393 patients with sentinel lymph node had then a full lymphadenectomy. In 41 cases, there were positive lymph nodes. 36 had at least one positive sentinel lymph node. So the negative predictive value, and that's the very important point, the negative predictive value was also very high in that multi-center prospective setting. So one of the big questions that is always debated is a sentinel lymph node indicated in early stage endometrial cancer, meaning stage 1B, 1A, G1, G2? I think that yes, because the famous risk stratification looking at low, intermediate, or high intermediate or high risk endometrial cancer can only be done postoperatively. And there were 2 very interesting studies published last year. One, the first one being coming from the group of Aborustum, where they actually looked at 959 patients with endometrioid endometrial cancer. I'm not going through all the table, but I'm just going to show you those 2 important numbers to me, because we don't know exactly what to do with ITC. I think that's one of the question that has to be answered in the future. But when you speak at micro and macro metastasis, I think it's important to realize that even in a G1 tumor, as soon as you have a 1B G1, you already have 10% of sentinel lymph nodes with metastatic disease. And if you have an invasion of the myometrium at all in a G2 tumor, in a 1BG2, you might have even 20% of the patients having micro and macro metastasis. So we don't want to miss those patients, and that's why it's so important to do sentinel lymph nodes in early endometrial cancer. The other very interesting study was the study by Price, another American study, which actually where they analyzed 162 or nearly 162,000 histologies. And in that paper, they could demonstrate that if you have a 1A moderate, meaning a G2 tumor, and you have LVSI positive at the final histology of the uterus, you have in 16.4% of the cases positive lymph nodes. If you have an invasion of the outer part of the myometrium, independently if you have a well or moderate differentiated endometrium cancer, in more than a quarter of the patients, you will have micro and macrometastases in the sentinel lymph nodes. And that's why it's so important to really do sentinel lymph node also in early stage endometrial cancer. We looked at our data just 2 years ago together with Liliana Mereau. We looked at 279 patients. In 103 cases, we had no sentinel lymphadenectomy, no lymphadenectomy at all. 58 patients had, according to the frozen section of the uterus, a pelvic and portic lymphadenectomy. And in 118 patients, we performed sentinel lymph nodes. First of all, we were interested how the morbidity was when we compared no lymph nodes to sentinel lymph node. And it was really reassuring that we didn't have any statistical differences between those two groups. Blood loss, operation time, and postoperative complications were the same. However, what we could demonstrate is actually that the disease-free survival was better in patients having had a sentinel lymph node, and even the overall survival was better in patients having had a sentinel lymph node when we compared it to the patients which had no lymphadenectomy at all, neither sentinel nor a normal lymphadenectomy. So this difference was not statistically significant. However, there was a real trend. So I think that in early stage endometrial cancer, especially in G1 and G2 tumor, we should do the sentinel lymph node. How is it with the high-risk group? We looked at that in our patients, where we actually looked first at the sentinel lymph node in G3 tumors and then performed a whole lymphadenectomy. When we had a negative sentinel lymph node or no sentinel lymph node, we just went through the normal sentinel lymph node algorithm, and you see that negative predictive value was very high. So even in high-grade endometrial cancer, it seems that the sentinel lymph node is or might be important. So I was very happy when last year the results of the CENTER study were published. That's a prospective multi-center cohort study where all patients underwent sentinel lymph node and then followed by pelvic and or portic lymphadenectomy. 156 patients were included. Sentinel detection rate was 77.6% bilateral. That's an important one. And you see that out of 27 patients with nodal metastases, 26 patients were correctly identified by the sentinel lymph node algorithm. So the negative predictive value was also very high in that group. So the conclusion of the Sentinel study was that the findings suggest that the sentinel lymph node is a viable option for the surgical staging of endometrial cancer. So there we need more evidence. However, ultrastaging has an added value also in those patients because it allows you to find microscopic disease. So I think that it's very important to find the good and right sentinel lymph node. So if you are interested in that, we have our technique on YouTube in our channel, so you can watch that. I'm going to skip that video for time reasons, but you can always go and look at the video. So how is it with ICG in ovarian cancer? I think that here we don't have a lot or not enough evidence. But it seems actually with two studies that also in ovarian cancer, the sentinel lymph node might be helpful. This Italian study showed that it was actually feasible in 31 patients. So, but to have any conclusion, they need 160 patients. So I'm looking forward to have those results. And the other study, the Sentinel study, actually a phase 2 clinical trial, included already 20 patients with technetium and ICG. And here also the conclusion at the moment is that the sentinel lymph node mapping in early stage ovarian cancer is feasible. But as mentioned, we need more evidence for that. How is it in vulvar cancer? And I think here it's very important to realize that we need to have to really be sure with the sentinel lymph node in vulvar cancer. And that's why we actually use a combination of technetium and ICG. We operate with the VTOM, that's like a colposcope, directly put externally, and use ICG instead of blue because of the number of side effects. We just submitted our first results, and for us it was very interesting to see actually that the sentinel lymph node detection rate with ICG was higher in positive lymph nodes, meaning when we had metastases, than the sentinel lymph node detection rate by technetium. And as soon as you have a lymphatic space invasion, it might also be that ICG is better than technetium, but as mentioned, the overall detection rate in our series is always ICG and technetium, because often it's easier, especially in obese patients, to find the right way looking at the gamma probe and then to recognize the sentinel lymph node by the ICG. There's another study who actually also looked at the same technique, meaning a combination of technetium and ICG in vulvar cancer. That was a randomized controlled trial. You see on one hand ICG technetium, on the other hand ICG and blue dye. And actually even in that randomized study, the conclusion was that the intraoperative visual detection in patients with vulvar squamous cell cancer using ICG was superior compared to technetium and blue dye. So I think that there also in vulvar cancer, it will become more and more standard. You might also use ICG when we have some complications. So for example, here we had a patient having a lymphatic fistula. We tried everything to treat that lymphatic fistula. Finally, there was only the surgical way to look at it. So we injected ICG between the first and the second toe, did a laparoscopy, and there you see how the lymph vessels, so we saw where the lymph fistula were. We did actually suturing and coagulation of those vessels, and the patient was then without any problems for the future. So that was the oncological part. But I think that also in gynecology in general, ICG becomes more and more important. We know, for example, that ICG is important for vascularization, and vascularization is an important feature in endometriosis, meaning that like in metastases, as soon as an endometriotic nodule wants to become bigger than 2 square millimeters, you need a neovascularization. And we might see that using the ICG. So we are very enthusiastic and looked at the visualization of endometriosis with laparoscopy. However, our enthusiasm was not as, yes, finally, actually, we could see a small or added value of the ICG in the normal diagnosis of endometriosis. However, and I think that's more important, ICG is very useful in deep infiltrating endometriosis. So you see here, for example, ICG injection in the ureter when I just come to talk about that. There was a meta-analysis done by an Italian group, and here also they had the feeling that ICG appears useful in the evaluation of vascularization in intestinal anastomosis, that's for sure, but also in the diagnostic tool in general. So they were concluding that the usefulness of ICG as a tool in detection of endometriosis was also in their hand inconsistent. So where do we use ICG actually in deep infiltrating endometriosis? First of all, when we have to do a shaving of the bladder, for example, when we have a bladder nodule, you see here the shaving we had to perform, and you see here the ICG in the bladder. So it helped us really to find out the right plane and to be sure that we have no leakage. Then when we want to identify the ureter in deep infiltrating endometriosis, you see we inject the ICG in the ureter, and actually that ICG stays for about 5 to 6 hours, and often it's you see it better after a while than at the very beginning. So if you have, like here, some deep infiltrating endometriosis in the rectovaginal space, it helps you really to find out, to see the ureter, or like here, the famous water under the bridge, the ureter going directly into the bladder. So that's, we don't use any double G anymore, we use ICG if necessary. Also, when we look at deep infiltrating endometriosis, and those are a little bit older images, it helps you to find the plane between normal tissue and the endometriosis, because around the endometriosis we have fibrosis, and ICG allows you exactly to see the plane where this fibrosis is. So in deep infiltrating endometriosis, it seems that ICG is very helpful and useful. One of the last thing we looked at, and that's very preliminary, is actually the use of ICG to determine the uterine vascularization during myomectomy. So when we perform a laparoscopic myomectomy, we usually clamp the uterine arteries, and then we inject ICG intravenously to see if there are still big vessels that we might to avoid during the surgery. So it works, but I don't have only preliminary experience. I don't have any data to show you. So I think that ICG changes the way we perform gynecological surgery. The sentinel lymph node biopsy will become more and more important in gynecological oncology, especially when performed through minimal invasive surgery. So in cervical cancer, as mentioned, we use ICG only, the same in endometrial cancer. In endometrial cancer stage 1A, G1, G2, 1B, G1, G2, most of the time we do only the sentinel lymph node. If they are positive, then we perform a pelvic and aortic lymphadenectomy. ICG is cheaper, has a higher bilateral detection rate than any other tracers, and you might use ICG also in other indications like endometriosis, fistula. I didn't say anything about breast cancer, but it works also in breast cancer surgery to look at the sentinel lymph node, or for the plastic surgeons, and colon surgery. Thanks to the combination of a high qualitative 4K picture and a crisp and clear superposition of the ICG, I think that more and more indications will come, and ICG allows the step from minimal invasive surgery actually to minimize surgery, or even to minimalize surgery. Thank you very much for your attention, and I'm very happy to answer your questions.
Thank you very much, Professor Mueller. Thank you very much for your amazing talk and your exciting videos. So it's really a didactic exposure of ICG. We're waiting for questions from the audience. So as a reminder, you can still submit questions through the questions and pane your attending at this panel. So we have some questions, but for the moment, I would like to ask you some questions about ICG. It's really an amazing tool for Sentinel node in gynecology oncology, for sure. In your practice, do you perform ICG Sentinel node biopsy in all endometrial cancers? So high risk, low risk for all endometrial cancers, even serous papillary endometrial cancer?
Yes. Actually, in those we still do a full lymphadenectomy, meaning if we have then G3 or serous or other special histology, we always perform then a full laparoscopic lymphadenectomy. However, I think that it always gives you an added value because the sentinel lymph node is really the one on which you can do, or on the one you do the ultra staging. And I think that the ultra staging allows you to find out microscopic disease or macroscopic disease that might be, especially in those specific or special forms of endometrial cancer, very important. And I think that in low grade, I think the future will be a combination of molecular and sentinel lymph node, because if we look at the molecular classification now, the only thing that is really changed is the Pol mutated and for the P53 positive. All the rest, they all looked at the LVSI or at the sentinel lymph node. So I think that even if you perform molecular techniques, it's important to have a sentinel lymph node.
I completely agree with you. So I understand that the difference is you have a medium high risk endometrial cancer. If your detection rate is not okay, or you cannot detect the sentinel node, you are going to perform the complete lymphadenectomy, but not in low risk endometrial cancer.
Exactly. And I have to admit also that with the new systems that are available now, it's really seldom to have a negative sentinel lymph node because you can always re-inject and then look at it again. So it's very seldom.
Mm-hmm. I have here a question from the audience. So can you explain a little more when you do unilateral versus bilateral sentinel lymph node dissection?
So we always do a bilateral. So that's the goal. It's really to find a sentinel lymph nodes on both sides. If we have a sentinel lymph node only on one side, and as you mentioned, we have a high intermediate or the high risk endometrial cancer, we always then, in the high risk, we always perform the full lymphadenectomy. With the high intermediate, we might do the unilateral lymphadenectomy. But the goal is to have a bilateral sentinel lymph node.
We have here another interesting question from Ryan Kinlan. So at the onset of performing ICG at my center, do you recommend doing ICG and full lymphadenectomy until we are more comfortable knowing we have the sentinel node, or directly to sentinel node?
I think that's the very difficult question. I think in the, as you mentioned, I think in the low grade and low intermediate, I think there it's enough to have the sentinel lymph node, because there are people that say that we even don't need the sentinel lymph node in those patients. I think in the other patients, high intermediate and high risk patients, you always should do lymphadenectomy, full lymphadenectomy, the high risk, and the high intermediate at the beginning, you should also do a full lymphadenectomy to be sure that you didn't miss any sentinel lymph node. I don't know what's your practice.
That's okay. So, some technical questions. Let me do some technical questions. So you are really an expert in ICG detection. So in your experience, which is the best dilution of ICG, and which is the best point to inject in the cervix? Which is your real practice injecting ICG?
So I think that's already a religion question. So we did inject until now always, we diluted with sterile water, 25 milligram with 10 ml, and injected in the past 2 milliliter at the 4 quadrants. But now, because the view is much better than the past, we are about only half of the volume. So now we still dilute 25 milligram in 10 ml, but then only inject 1 milliliter, but on every quadrant. So there are a lot of different ways to do it, but I think, and we compared our results with another group who injected a lower concentration, and finally we might have a little bit more sentinel lymph nodes in our group, but there was no statistical difference.
Yes, I completely agree with you. I think that a low concentration is enough, so it's not really relevant to inject a lot of ICG in the cervix, no. But for sure, in the cervix for both tumors, cervical and endometrial cancer.
Yes.
Yes. It's not necessary to do an hysteroscopy to inject the fundus uterus, so it's really not needed that.
No, actually, to be honest, we did exactly the same study as the Italian, but they were faster than we are. So, and I was happy to see the results, so we could stop the peritumoral hysteroscopic injection, because it's much more complicated and it doesn't add anything at information. So we just injected in the cervix. Yes.
We have one question from Sergio Casillas. So are there any contraindications for ICG injection?
Yes, the only one to me and to my knowledge are iodine allergies. So if you have, we had one bad allergic reaction, and this patient mentioned that she had allergy when she had, how you call that? Not the fish, the other one, the crustaceans, so crevette, and also she had a hidden iodine allergy. And that's the only one case we had with an allergy reaction. Otherwise, I think there are no other contraindications.
Yes, some crossing allergies with iodine. Yes, perfect. Another question. Is it possible to use ICG alone to identify the sentinel lymph node in vulvar cancers, or you use the technetium combined every time?
In vulvar cancer, always with technetium, because I think that especially in obese patient, it's very difficult often to see where to do your incision. So at the moment, with it's easier just to have the technetium, then it allows you to see where to do the incision, and then you see the lymph vessels nicely with the ICG.
So I understand that the previous gammography of the field is the technetium is really useful for localization,
yes.
Where to do the incision and where to do the ICG detection after. Yes, I understand you.
Exactly, yes.
And why not for pelvic cancer for that? The gammography to localize for a localization, previous localization, and where is the lymph node? Because we have, as you have mentioned previously, it's very difficult to localize where is really the sentinel node in a green channel of all the green channel of lymph nodes.
Yes, too expensive for Switzerland. No, I think that's the good thing with the ICG. If you inject it after you are already starting your laparoscopy, you really see where the lymphatic channels are going. So you really see the sentinel node, the real one. And that's why it's really enough for cervical and endometrial cancer. I think in vulvar, one of the really important things is really the fact that you don't see it over the skin if it's an obese patient.
Yes, again, some tricks to identify where is the real sentinel node.
The real trick is really to follow the lymph vessels. As you see, and I'm very amused because there are a lot I've seen in the last, I think 2 weeks, 2 videos from the industry where actually you saw very nice sentinel lymph nodes or green lymph nodes on the iliacal external artery, but you also saw the lymph vessel coming from up. And I think that's exactly the point. As soon as you have a green lymph node, follow the lymph vessel until you find the lymph node. Sometimes it's true, they are there, but then you see only one small lymph vessel going up. And I think this is the important part. You have to follow the lymph vessels to find the real one.
So, okay, thanks, Professor Mueller. So it's the statement in endometrial and cervical cancer with sentinel lymph node and ICG is down. So it's that is okay. We have enough evidence to do that. Yes. I have another question in a research field from Baif Abdullayev. Where do you inject ICG for ovarian cancer?
So there are two ways to do it. Either you have an ovarian cancer where you still have the infundibulopelvic ligament, then we inject it in the infundibulopelvic ligament just under the peritoneum. Or, and that has been shown in the CENTOF study nicely, that if you already had an adnexectomy, for example, you might inject the ICG in the ligamentum ovari proprium just at the uterus, at the level of junction to the ovary to the uterus.
Great. I have a lot of questions about the topic of endometriosis and ICG. So it's really new. It's really new that. So some people ask about where to inject, how administrate ICG for endometriosis. Same question for ureters identification.
Yes. So to look at the endometriosis, to find more lesions, to be honest, I'm not so sure that this is very useful. Then you inject it intravenously, 1.5 milligram per kilogram. And then if you want to see the ureter, then we inject a dilution here, a higher concentration. We don't dilute 25 milligram in 10 ml, but only in 5 ml. Then we go with the catheter in the first 2 centimeters of the ureter, and then we inject it. I think it's important to give some pressure on that, because if you have a stenosis of the ureter, sometimes it's more difficult to go over that stenosis. But then, and that's very interesting, because I thought, it would disappear after 1 hour, but usually it takes 5 to 6 hours, because I think that it's with the movement of the ureters, it's going in the wall of the ureter, so you can really identify the ureters nicely during usually 5 to 6 hours. Then that's the way we usually use it, and I have to admit that we don't use any double J anymore. Sometimes, if the patient has already a double J before the operation because she had a stenosis of the ureter, for example, we perform a extensive uterolysis. Then if we don't know if we had a vascular lesion of the ureter, we inject the ICG intravenously. And then we see it coming around the ureter, and then we see, okay, the ureter is still vascularized, so it shouldn't be a problem postoperatively. Then the next topic is the topic of endometriosis resection when you perform bowel surgery. So there, when we do a shaving, we inject it intravenously at the time when we do the shaving, because that allows us to see the plane between nodule and the bowel. And if we have to perform a resection, a bowel resection, then we do that, we inject it just before doing the resection to know which part we have to resect, that we have a good vascularization after reanastomosis.
So read that, in fact, we have for gynecology 2 different uses of ICG, no? The ICG intraparenchyma or peritumoral to see the lymph nodes, to see the chain of lymph nodes and the sentinel node, and the other uses intravenous to see the vascularization of the ureter, of the bowel, of the colon, so great.
Exactly.
So I think we are more or less on time. It's really an amazing topic. It's an amazing topic for me and for you. And I think that for everybody that's working in gynecological oncology, the use of ICG, just your conclusions are perfectly explained. But in my sense is ICG is extremely the better than the other traces for sentinel lymph node detection in cervical and endometrial cancer, for sure, especially for the bilateral detection rate. It's very, very important. And the cervical injection is enough for these both tumors. It's not necessary to achieve another complications with hysteroscopy or another ways. So it's really okay. And then that ICG is an excellent tool, really useful for other fields, so for endometriosis, for labeling the ureters, as you have shown, really perfect. So really thanks everybody to be connected with us this time. Really thanks Professor Mueller for this amazing talk, and really thanks the International Society for give us this opportunity to be here together today. So thank you very much, everybody. Thank you very much.
Thank you very much to you too for the great moderation, and to FSGS for giving the opportunity to give this talk. Yes, thank you very much to everybody too.
Thank you very much, gentlemen. Once our audience leave our webinar today, you will receive a survey on the presentation, and we would appreciate it if you could complete that and provide your feedback. We will also send you a follow-up email within 24 to 48 hours, which will include a link to view a recording of today's webinar. On behalf of the International Society of Fluorescence Guided Surgery, with grant funding from Diagnostic Green and our presenters, thank you so much for joining us today, and please do enjoy the rest of your day. Goodbye.
Thank you.